Uh, Today we have what I'm thinking should be an interesting presentation by folks from RTI, giving a talk on recapping applications of RTI's COVID-19 agent-based model during the COVID-19 pandemic. We have 4 presenters today. We have Joella Adams, a research epidemiologist within RTI Center for Applied Public Research. Casey Jones is a data science within RTI Center for Data Science. Sandy Price, who's also a data scientist within the Center for Data Science, and Emily Hadley, who works there as well. They're going to be talking to you about the North Carolina Modeling Infectious Diseases agent-based model and its application to COVID. So I'm going to hand it off. I think Casey's going to be coordinating everything. So thank you all for being willing to present. We're looking forward to hearing what you have to say.
Thank you, Harry. Yeah, so we signed up for this presentation back in October of 2020, thinking we would talk about the latest things that we have done to the model. But since then, the 2 projects that funded a lot of the more recent research have ended, and we thought this would be a good opportunity to not only present those final few things that we worked on, but also kind of recap the modeling efforts as a whole as they started back in March of 2020 all the way up through April 2022. So we're going to go through a few different things related to all of the work that we've done. We've got several people on the screen, but we really make up over 20 folks, I think, at this point have contributed to this model. And so I don't want to list or talk through all of us, but just know it's a large effort from a lot of different places. We have had several different funding sources over the past 2 years, but it even goes back all the way to 2017 when our original agent-based model started. And then we've had several different contributions from folks of different organizations over the past several years as well. So we just wanted to acknowledge all of those funding sources as well as all of those contributors. A quick agenda for today. We're going to do an introduction on the model itself. I mentioned that we started in 2017 or so, and COVID wasn't around. So we weren't doing a COVID model back then. So I'm going to go over the original model and a little bit of its background. And then we're going to start going through the different uses of that model as it's related to COVID. So we're going to talk about our work in 2020 with North Carolina Department of Health and Human Services. We're going to talk about a lot of the major updates that we did to the model after the first year or so of the pandemic to get ready for the final types of analysis that we've been doing the past year or so. And that's looking at the asymptomatic entries into different facilities and as well as some preliminary social network analysis that we've done. Our original agent-based model was of North Carolina, and it was for healthcare associated infections. And our goal was to look at those infections, see how often they happened, and then try different interventions on those infections to reduce the transmission. So we built an agent-based model of North Carolina, and we modeled different facility types: hospitals, nursing homes, and long-term acute care facilities being the 3. And this map just outlines where all of those facilities are. And there's over 500 of them, primarily being nursing homes. This map shows how people can get between the different facilities in the model. We generally have everybody in the community, and that just means they're at home, right? They're not at a facility. But they may seek treatment at some point during the model, and they may go to a nursing home or a hospital. And these arrows kind of show you how individuals can get between different facility types. The simulation itself, though, each individual facility is a node in the model. So we do have over 500 different nodes that people can go to and go between throughout the model run. Agents in the model are represented using RTI's synthetic population, and that's a representation of all the people that live in North Carolina. Currently, that's about 10.6 million people, and we have different attributes for all of those individuals. In the model, we only make use of sex, age, county, and then a couple others that we assign to those individuals, being vaccination status and if you're a healthcare worker or not. But the synthetic population itself has a lot of variables that we currently aren't using. We also have in the model time varying agent variables, and those are updated daily. So we have a daily timestamp for our model. The three that we're currently looking at, life status, are you alive or not? Location, are you at home? Are you in the community, or are you at a facility? And then finally, your COVID-19 status. And this just represents whether you have COVID or not and how severe your COVID case is. And we'll talk more about these individual statuses in a moment. The case assignment for COVID, there's been so many folks doing research on this for like forecasting cases and trying to predict, the spread and when it's going to slow or if it's going to pick up. And so we did do some of that through SEIRS models. So we do have that capability to kind of forecast 30-day case estimates, but we also have the ability to use past case estimates. So for example, you would use the first one, the SEIRS models, if you were trying to forecast into the future what might happen. And then you would use the second one if you were kind of looking back to say, hey, what happened in March of 2022? And we want to run different interventions that might kind of change what happened in that month or see what might have happened. These case counts are used as input into our model, and agents are assigned COVID equivalent to the number of cases that we tell it. So if we say, hey, make 100 cases, the model is going to make 100 cases. We select someone from the community who is susceptible to get COVID, and then we assign them a case severity. And we'll talk a little bit about that severity process in a moment as well. These two graphics just kind of outline what I said a little bit more visually. So you've got the SEIRS kind of giving you case counts. The ABM picks people in the community who are susceptible and assigns them COVID-19. And then once you have that designation, you then get a severity. And the severity is going to determine how the model treats you and what it does with you. So if you're a COVID-19 agent, you get one of 4 different severities. You could be asymptomatic, which means you don't seek hospitalization, you don't have any behavior changes, you don't know that you're sick. You could be mild to moderate, which means you definitely have symptoms, but not severe enough to seek hospitalization, but you might change your behavior. So the only 2 behaviors that we currently alter is if you're visiting someone in a nursing home. So you're going to visit a friend or a relative, you may decide not to visit them because you're sick. Or if you're a healthcare worker, you may decide not to go into work because you're sick. Now you may be forced, depending, but we kind of simulate that through randomness in our model. And then the last 2, severe, meaning you're severe enough to need a hospital bed. So you would go to the hospital in our model, or critical, you would go to the hospital and you would actually seek an ICU bed because you have very critical symptoms. Both of those agents are discharged from the hospital once a length of stay is completed. And the length of stay is randomly assigned, but it is using historical length of stay values. To initiate the model, it just depends on what data you currently have available. You can either use parameters to say, fill each facility to some number, 60%, 70%, whatever that value might be. Or if you actually have data by hospital, you could fill the hospital beds in each facility using data. That could be the number of COVID individuals at hospital A, the number of non-COVID individuals at hospital A, and so on and so forth. So you can fill it if you have data. You can fill the hospitals and nursing homes if you don't have data. Nursing homes and LTACs always use a parameter, so it's always 70% full or 85% full, whatever number you want to use. But we try to use a historical number that kind of represents reality when picking those parameters. And then as far as COVID goes, we do start infection in the community on day 1, and that's using our SEIRS output for the level of infection, which is the I in the SEIR model, because we have people going into nursing homes and going to visit folks and working. And so we need that underlying infectious value to help with some of our analysis. I'm going to pass it to Emily to talk about our work in 2020 with NCDHHS.
Thanks so much, Casey. Hi, everyone. I'm Emily Hadley, also a data scientist, and I'm going to be talking about one of our applied use cases for the model that Casey just described. Back in 2020, in the early stages of the pandemic, we partnered with the North Carolina Department of Health and Human Services to use our model to provide answers to them to help in their decision-making process. Next slide, please. So the key question that we identified in partnership with our North Carolina Department of Health and Human Services stakeholders was this question of, will demand for hospital beds exceed available hospital beds in North Carolina in the next 30 days? And the reason this question was relevant, especially at the beginning of the pandemic, was we didn't really have a lot of information to answer this question. And also the stakeholders needed to be able to make rapid decisions on things like, should we increase our surge capacity? Should we pay attention to staffing? Should we make decisions that allow us to ensure that we're going to be able to address this demand? Because we were witnessing that other locales were having their demand for hospital beds exceeded. And so from a forecasting perspective, we were really interested in forecasting 2 items: demand by COVID patients, certainly, because that was the issue of interest at the moment, but we also needed to forecast demand by non-COVID patients as well, because just because the pandemic was hitting it in place, that didn't mean that there also weren't non-pandemic patients that were also requiring some degree of hospitalization. And we did separate our forecasts into non-ICU and ICU forecasts, because the intensive care unit, ICU, requires a different level of treatment than non-ICU beds, and these oftentimes reflect different patient needs. Next slide, please. So this was a pretty rapid response that was required, and we put together a fairly large team to address this challenge and this question. The team of data scientists, epidemiologists, public health experts, technical and visualization consultants, project managers, and statisticians. The timeline on the bottom of this slide highlights just how fast our response was. So it was back on March 3rd, 2020, that we started kind of thinking about what a COVID-19 model might look like. That aligned with an executive order that was passed around a week later, which we had our first prototype COVID-19 simulation model. We were able to support NCDHHS with 2 briefs that we released in the month of April. And then starting in May, we provided weekly deliverables to stakeholders at NCDHHS to help facilitate decision-making. We used a variety of tools for this project. Python and R are both open source software tools, and then Tableau was our visualization tool. Next slide, please. So what did we actually provide to help with answering this question? We provided both forecasts and nowcasts, and these were both at the statewide and regional levels. The process was that we would run the model that Casey described under different scenarios of SARS-CoV-2 spread. And then we would provide 30-day forecasts of that demand for both ICU and non-ICU beds with validation and quality checks. We also provided separate nowcasting effective reproduction number estimates to give a sense of how quickly we thought the disease was being transmitted throughout North Carolina. I'll go into the model output more on the next slide, but some of the example model output was the hospital bed demand, which is what we've been discussing. We were also able to use the demand to then forecast the need for skilled nursing facility beds from COVID-19 patients discharged, as well as a census of hospitalized COVID and non-COVID-19 patients. The variety of deliverables I'll discuss next, but I just wanted to note that the regional approximations or the regional forecasts that we did were the North Carolina Local Health Directorate regions, and that's visualized in the map on the bottom right. And these were really helpful for some of the local health directors who serve each of these regions. Next slide, please. We put together 3 deliverables each week from May through December. And the reason that we put together these 3 deliverables is they were meant to align with different audiences. So the first deliverable that we would put together is this Excel, noting that all of the data in this slide is not intended for interpretation. And the Excel file is kind of the numeric output from the model. There's a lot of information there. It's really neat to look at, but it can be a lot of information to consume. And so the next piece that we put together was Tableau. If you've used Tableau before, you might be aware that it can be an interactive way to work with visualizations. And so the Tableau was intended for a data analyst or epidemiologist or someone like that who might be interested in playing around with our dropdowns to see the outcomes of various scenarios. And then the last piece that we put together was a PowerPoint version, which effectively distilled the Tableau into static images of the most likely scenarios. And the purpose of the PowerPoint slides was so that they could be emailed very quickly, they could be discussed by high-level stakeholders within NCDHHS without requiring the need for interactivity in Tableau. And that PowerPoint slide, which you're looking at in those 2 figures is one figure is for non-ICU beds on the left, the other figure is for ICU beds on the right. The blue line represents our forecast over the next 30 days. And the red line, which is a little bit small here, is the total capacity for inpatient beds in North Carolina, either non-ICU or ICU. And what we're looking for is if that blue band gets close to that red line or exceeds it, because that would suggest that there's some possibility to exceed demand in the next 30 days. Next slide, please. So we provided these results each week. One really important lesson learned was that because these results were going directly to stakeholders who were making really rapid decisions with some of our findings, we wanted to make sure that we did a lot of validation on our end before these results were shared. So we put together a validation process that included first an initial review by the data scientist who was running the model that week, as well as a secondary data scientist whose job was to QC the work. That would include comparing current estimates with estimates from previous weeks. We're really looking for really big jumps that might be unexpected, as well as identifying bugs in the model run. The second piece was to have a review by an epidemiologist on our team. They would compare the estimates with observed North Carolina Department of Health and Human Services data and comparing estimates with other groups who are making estimates to see how ours compared and if they were in alignment. And the final review is for accuracy of our documentation that were prepared with the deliverables, as well as providing additional context so that the stakeholders could accurately interpret the deliverables that we were providing. Next slide, please. So we have published our results. They're available in this kind of article title that I have quoted up in the top right corner of this slide in infectious disease modeling. This particular slide is showing what we actually forecasted, so the values that we forecasted. The top plot here is for non-ICU demand measured in beds, and the bottom plot is for ICU demand measured in beds. The x-axis is the date of the forecast. So we provided those weekly forecasts. The reason this particular plot starts in June is because that's when the numbers were available, and then we tracked this through November. And then the y-axis is the count of the number of beds. The circles represent what we actually forecasted with a 25th and 75th percentile band. And the triangles reflect what was actually needed in the North Carolina Department of Health in North Carolina in that particular week. So you can see that from June through October in particular, we were in some cases pretty far above with ICU and a little bit below with non-ICU. And I'll talk about the vertical lines in just a moment. Those different dashed and circled lines reflect some key changes that we made that improved our predictions. Next slide, please. So in addition to the last slide reflected what we actually predicted in terms of beds, this slide reflects the error in our prediction relative to what actually occurred. So the top plot here is the mean absolute error, and the bottom plot is the mean absolute percentage error. with the mean absolute error being counted in the number of beds we were off by, and the percentage error being the relative difference. We can see that in general, the mean absolute error was higher for the non-ICU estimates, particularly in the September to October time period, and that the mean absolute percentage error, the MAPE value, was higher for the ICU estimates, particularly prior to September. Now, noting those three kind of dashed and dotted lines, they reflected three key changes that we made to the model. The first was in August when we made an adjustment in how we calculated county R values. The second change that we made was initialization of non-COVID-19 agents in hospitals in September, once we got some additional data that allowed us to know how many patients were in hospitals at a given point in time. And then the third big model change we made was in October, when we were able to update location transition probabilities with the hospital occupancy data as well. And the quote down at the bottom of this slide is one of the key findings of the paper, which was that integration of near real-time hospital occupancy data into the model significantly improved the forecast, reducing the average MAPE for non-ICU beds from 6.6% to 3.9%, and ICU beds from 33.4% to 6.5%. Next slide, please. This is also a table summary from that same paper. This kind of summarizes what those changes looked like when we integrated the hospital occupancy data. And the hospital occupancy data was a survey provided to all the hospitals in North Carolina that were also included in our model that reported on how many patients they had in both ICU and non-ICU beds every day. So this was the most accurate data that we could get. It's worth noting that this data wasn't available for a while. And I think that one of the outcomes of the pandemic was to make this data more available, both to state level stakeholders as well as to researchers like us. And so if some event were similar to happen to this in the future, where we wanted to forecast hospital demand again, we definitely would suggest using hospital occupancy data where possible, because it definitely improved our forecast pretty significantly. Next slide, please. So yeah, that was a really great project. We wrapped it up in 2020, and we're excited to be able to share the results of that work publicly. I'm now going to pass it over to Sandy, who's going to discuss some of the model updates since that point in time.
Thanks, Emily. For the remainder of the presentation, we're going to be discussing some results from other analyses that we've conducted under other funding mechanisms since our work with the state of North Carolina wrapped up. I'll begin by introducing some updates that we made to the model in order to facilitate those analyses. I'll then hand it over to Joella to talk about our first analysis, and I'll wrap it up by talking about a preliminary social network analysis. So to begin, I'll just do a quick overview of the model updates. We're not going to dive in too deep here just for the sake of time. Next slide, please. And in particular, I'm really going to gloss over the details for our vaccination module. This should be relatively straightforward. I mean, we needed the ability to assign agents as either vaccinated or unvaccinated. And the mechanism in the model essentially is that at initialization, each agent is given a vaccination status. We can adjust various parameters to determine who's vaccinated and who's not. And if an agent is vaccinated, then throughout the simulation, they have a reduced likelihood of infection. If they are infected, they have an increased likelihood of being asymptomatic and a reduced likelihood of hospitalization. Next slide. The second feature that we added to facilitate these analyses was a nursing home visitation module. So all of our residents who are in a nursing home are assigned anywhere from 0 to 3 visitors from the community when they enter the nursing home. You can see a plot on the right there showing the distribution of the number of visitors per resident. And this was based on subject matter expertise and some recent research. Depending on the visitor number, each visitor has a daily probability of visitation. And then as the simulation runs, we simulate visitation for every assigned visitor on every day. In order to actually visit the resident, they have to pass through several barriers that have to be randomly selected based on that probability of visitation. They have to still be in the community, in other words, not in a hospital or nursing home themselves. They can't have severe or critical COVID symptoms. And if they have mild symptoms, we have a parameter to control the likelihood that they would choose not to visit their nursing home because of those symptoms. And we set that at 60%, but that is flexible. Next slide. The final feature that we added, it was healthcare worker attendance. And I'm going to get into more of the details of this when I talk about the social network analysis later. But just to introduce the concept now, we wanted to be able to keep track of which agents in our model were healthcare workers and when they were going to work and where they were going to work. The way we did this was calculating the number of workers per facility. Once we had that number for each facility, we could randomly select some agents to become healthcare workers. We largely do that by proximity. So for a given facility, the workers that we select, or the agents that we select to become workers for that facility, are generally close in our geospatial model. And once we have a bunch of workers assigned to each facility, we simulate and track their attendance to work throughout the model run, and we can keep track of their COVID status and vaccination status as they go to work. So again, more on this when we talk about the healthcare worker network analysis later on. For now, I'm going to hand it over to Joella to talk about our first analysis.
Great, thank you, Sandy. My name is Joella Adams. I'm an epidemiologist at RTI, and I'm going to be discussing a recent analysis that we did using the microsimulation model to estimate the number of undetected SARS-CoV-2 individuals entering into short-term acute care hospital settings during the Omicron surge. Next slide, please. So there's limited data to inform how many individuals acquire SARS-CoV-2 while admitted into hospital settings. In the United Kingdom, where they have some improved surveillance for this, the percentage of admitted patients who acquire SARS-CoV-2 while inpatient ranged from 11 to 25% over the last 2 years. There was a recent Kaiser Health Permanente report that used inpatient hospital data and estimated that more than 10,000 patients were diagnosed with COVID-19 after admission into a hospital, and a fifth of those patients died. A large reason for this is that people admitted into the hospital are going to be medically more frail and vulnerable, and therefore it's very important for us to have a better understanding of how these transmissions occur within hospital settings. In particular, the admission of patients with asymptomatic infection increases the risk of nosocomial spread. Next slide, please. So as of December 2021, the CDC recommended that testing for anyone with mild symptoms, regardless of vaccination status, was recommended prior to admission into a hospital. However, the performance of pre-procedure or pre-admission testing was at the discretion of the facility. This leads to wide variation in the policies that are set in place in the United States in hospital settings, and was a main driver of the reason we wanted to perform this analysis. In a survey conducted by the Society for Healthcare Epidemiology of America, they found that 98% of hospitals tested patients with respiratory symptoms for COVID, but only 64% performed pre-procedural testing of asymptomatic patients. And this was earlier during the first year of the pandemic and not recently during Omicron, which is of note, where many more people were estimated to be asymptomatic. Next slide, please. So the objective of this particular analysis was to use the individual-based model of North Carolina healthcare facilities to estimate the number of undetected cases of SARS-CoV-2 admitted as inpatients under 4 different testing approaches. Next slide. The first testing strategy that we implemented within the model was only testing symptomatic patients. So anybody with asymptomatic any infection would basically be admitted as an inpatient and not be indicated as somebody with COVID-19. The second approach was one-stage antigen or rapid testing upon admission, where people who tested negative were presumed to be negative. The third approach was one-stage antigen testing followed by confirmatory PCR testing for negative results on the rapid. And the final strategy was a serial antigen testing, where individuals were given a rapid upon admission, and then for those who tested negative, a follow-up rapid 2 days later. Slide. Now there's indications that there's a wide variance in the sensitivity of rapid antigen testing for detecting asymptomatic Omicron infection. We used a series of preprints as well as a Canadian government report that reported a sensitivity from 37% to 98% for detecting asymptomatic infection. And we used the middle of this range of 67% in our main analysis for the test sensitivity for detecting Omicron in asymptomatic individuals. We assumed a test sensitivity of 77% for PCR testing. And in addition, we assumed that 30% of individuals who recently had SARS-CoV-2 would be testing positive due to persistent viral shedding rather than true reinfection with a PCR. So this is known as persistent positivity and is also more likely with older individuals, therefore was an important component to include in this analysis. The specificity for both PCR and rapid antigen testing was set to 98%. Next slide, please. So over a 30-day period, which was representing the surge related to Omicron within North Carolina, so from December 15th, 2021 to January 14th, 2022, we had 77,980 hospital admissions to 104 acute care settings. 13.7% were for COVID-19 indications, so individuals with severe critical disease. 4.3% were with but not for COVID-19, so these are individuals with either mild or asymptomatic disease, and 82% were for non-COVID indications. Slide. Altogether, there were a little over 14,000 admitted inpatients with SARS-CoV-2 infection, and 7.72% of those were asymptomatic. So when we did not implement any type of screening for asymptomatic infections, this meant that a little over 1,000 individuals were admitted as inpatient with asymptomatic infection. So we can suppose that none of those infections were detected at any point and were a potential risk of transmission within the hospital setting. When we implemented one-stage antigen testing, we were able to detect 734 of those infections with around 1,200 false positives. A strategy combining a one-stage antigen test and PCR testing detected nearly all of the infections, but also had a very high number of false positives due to the persistent positivity, particularly during this period of time where infection rates were extremely high in the community. When we implemented a serial antigen testing policy, we also detected nearly all of the asymptomatic infections, with 973 infections detected, with around 2,500 false positives. Next slide. In conclusion, during a month-long surge related to the Omicron variant, our model estimated that nearly 10% of SARS-CoV-2 infections went undetected if no pre-admission screening for asymptomatic infection was performed. The combined antigen PCR testing and the serial antigen asymptomatic screening policies detected over 85% of the asymptomatic infections. The combined antigen and PCR strategy likely yielded many false positives due to persistent positivity, and therefore the serial antigen testing policy yielded around the same number of detected infections, but less false positives. The positivity of pre-admission testing and varied depending on the community prevalence and testing sensitivity, and we varied both of those within sensitivity analyses to evaluate the impact of those on our main findings. Next slide. I do want to note a couple of limitations related to this. One was that the model only simulated inpatient stays. So therefore, individuals who entered into the hospital setting for outpatient care or to the emergency department were not modeled, and the testing policies did not apply to them. There are other COVID mitigation strategies that would be more applicable for those individuals, such as masking or verbal screening for symptoms. We also implemented a population average for the vaccine effectiveness rather than varying it by timing of doses or immunosuppression. And there was no actual simulation of transmission within the hospital settings within the ABM, and therefore we could not simulate the cases which would arise from an outbreak within a hospital setting. I'll now turn it back to Sandy to discuss the preliminary social network analysis.
Thanks, Joella. So this will be the final analysis we talk about today. And I will stress that it's a preliminary social network analysis in the sense that we don't really intend this to be a robust experiment in the way that the other ones we've talked about so far today were. The intent here was more to demonstrate the potential of the healthcare worker features that we've added to the model and the way that social network analysis might be used to ask and answer some really interesting questions about healthcare worker networks. Next slide. I mentioned earlier that I will go into a little bit more detail on the mechanisms behind healthcare workers within the model, and I'll do that now. Our process for assigning healthcare workers to facilities at model initiation was driven by a data set from CMS called Payroll-Based Journal. It's a really cool data set that includes for every nursing home facility, the number of hours worked by employees and by contract workers per day. And it's really nice that they separate the hours worked by these two categories of workers, because they tend to have very different working behaviors. So employees typically are like salaried, generally work at a single facility, mostly work full-time. Although we did include in the model 15% of employees working part-time at a single facility, and another 15% of employees splitting time, 2/3 at a primary facility and 1/3 at a secondary facility. These numbers were informed by our colleagues who are nursing home subject matter experts and are variable in the model, as we'll go into later. These are some of the knobs that we can turn to adjust different scenarios and see what would happen under different conditions. Contract workers are generally hourly workers and generally don't work full-time at a single facility. So in our model, our baseline scenario is that all contract workers split their time between 3 different facilities. The location of agents who are assigned to become healthcare workers is largely driven by proximity to the facility. For employees, we're able to ensure that every employee lives in the same county as their primary facility. To get the math to work out for secondary facilities and contract workers, we choose them by proximity, which means they're not necessarily always in the same county, but generally in a neighboring county or close by. Next slide. So after model initialization, we've got a bunch of nursing home facilities. Each one of them has a staff of healthcare workers assigned to work at that facility. And each day attendance to work is simulated for each worker. And the way that works is very similar to the visitation module I discussed earlier. In order to attend work, a worker must pass several barriers, including the day being a work day for that worker, still being in the community and not in a facility, no severe or critical COVID symptoms. And we have another parameter here to control the proportion who would not go to work if they had mild symptoms. We assume that's a little bit higher than for visitors at 80% in our baseline. Next slide. So we're able to adjust some of the parameters driving this healthcare worker attendance mechanism to assess impacts on changes to nursing home staffing policies. And of course, we recognize that nursing homes are really struggling to keep up with staffing demands during the pandemic, and that their top priority is probably just to keep the doors open at this point. But our analysis here is just seeking to quantify the potential impact of changes to staffing parameters without really making any assumptions about their real world feasibility. So the way we did this is outlined in the scenarios at the bottom of the slide. We used 2 model parameters to adjust these various scenarios describing changes to staff policies. The first was the number of sites per contract worker. I mentioned that that's 3 in our baseline scenario. And we asked what would happen if contract workers worked at more sites or fewer sites. We also added a multiplier to adjust the original value determined using the payroll-based journal data for what proportion of hours for a given site was worked by contract workers versus employees. So we could say, what would happen if the proportion of hours worked by contract workers was half of what it actually is in the payroll-based journal data, or half again as much. Next slide. So the first result we looked at under these different scenarios was the number of shifts worked by a healthcare worker after being exposed to a mild or asymptomatic healthcare worker or visitor. So every time a healthcare worker goes to work and there's another worker there who, or visitor there who is COVID positive, we keep track of that worker for the next 3 to 7 days and ask how many shifts did they work at facilities other than the one where the encounter occurred. So this is a way of sort of getting at the potential spread from that initial exposure event over the next few days. The row outlined in red is our baseline. No adjustment to the proportion of contract hours and 3 facilities per contract worker. In the right-hand column, you'll see that's 334,000 shifts that were potential transmissions from that first exposure throughout the simulation period. And we can see if we reduce the number of facilities per contract worker, that goes down to 286,000. If we increase the number of facilities per contract worker, that number goes up. In the final 2 rows of the table, we see a similar mechanism where if we reduce the number of hours worked by contract workers and make those up by hiring full-time or by hiring employees, we could reduce that number of potential exposures from the initial exposure to 262,000. And conversely, increasing the number or proportion of contract hours increases these number of exposures. Next slide. We also explored some visual ways of representing this kind of spread of potential transmissions through healthcare worker networks. So these plots represent kind of a 8-day series of what happens after an initial exposure at a facility. So the red dot represents a nursing home where a visitor or healthcare worker was COVID positive. And the blue dots represent additional facilities where workers who are exposed to that initial exposure go on to work over the next series of days. An edge between, the weight of the edge between facilities here represents the number of shifts shared across those facilities. And this is kind of comic book style. So it starts in the upper left and ends in the bottom right. So on the left-hand side of the screen, we can see over this 8-day series, an initial exposure at the red nursing home leads to a really huge network by the end of this week of other nursing homes connected to that original one by healthcare workers working on multiple facilities. And on the right-hand side of the screen, we can see a similar dynamic, but when we reduce the number of contract hours by 50%, the ultimate size of that network is greatly reduced because overall our staff are working at fewer facilities per person. So the takeaway here is, pretty straightforward. Reducing the proportion of hours worked by contract workers or reducing the number of facilities per contract worker directly reduces the possibilities for worker-to-worker transmission. And we're really excited about this as a preliminary analysis, just demonstrating the potential of doing social network analysis on these nursing home staff networks to ask and answer a lot of really interesting research questions. And I will hand it back to Casey to wrap us up.
Thanks, Andy. I will try to go through the conclusions pretty quickly because I do want to save some time for questions. But early on, we recognized that we were learning a lot as we went. We do a lot of research at RTI, and not that we're slow by any means, but the pace at which we had to do the research and make updates to our model was just different for a lot of us. We were getting new numbers daily or weekly. We were getting new parameters. We had to make adjustments on the fly. We had to interact with our client all the time, multiple clients, a lot. And so we ended up writing a whole paper on the lessons that we learned throughout that 2020 kind of first year of the pandemic. And I'm not going to read through all of these. I just wanted to highlight a couple, primarily being that the models can't take forever to run. And if you have built simulation models, you've probably dealt with that some where you can hit play and then you can come back in a day or two and kind of see what you got. And we learned quickly that that wasn't going to be possible because we needed to run our models and get the results out the door as quickly as possible. So RTI invested in our own project to kind of speed up that process. And we really reduced how long it kind of took to do the entire pipeline from 4 hours to just a few minutes. So we could run the model, see what we got, make adjustments, run it again, and still turn around the deliverable pretty quickly. So the lesson there was just really planning for that and knowing that that's going to be an important step. And then also the automation is really important. We couldn't spend time doing manual steps. We had to have things automated. And then the last one, I mean, there's a lot here, but the last one I'll mention is just that stakeholder engagement. Talking to our clients regularly, setting expectations, really engaging with them and seeing what they were looking for, and then presenting those results in an interpretable manner. Emily mentioned earlier, we had a very thorough Tableau set up for a certain group of folks, and then we had also a distilled PowerPoint for a different group of folks. So having different options for different people was also important. And then just to conclude all the different things that we talked about, we took a model built for healthcare associated infections and rapidly changed it for COVID. And we've done a lot of different analysis and set up on that over the past 2+ years. All of our code is publicly available, so you can run any of the models that we've talked about today. It's all open source. There's nothing proprietary about it. It's all on GitHub. And any data that's also public is linked to these models. So the only data that we weren't able to provide is the kind of hospital data from 2020, because that was non-public, but everything else is readily available and all the models are available. And then, yeah, we definitely hope to continue doing some of this analysis, especially the network stuff that Sandy just presented. We were just getting to the tip of the iceberg of that analysis, and we're looking forward to continuing that for both COVID as well as the HAI work that we originally started several years ago. And with that, I will, definitely turn it over to anyone who has a question or just interest in the work that we just presented.
Great. Thanks to the team for that really nice talk. If you have any questions, please feel free to put some in the Q&A or raise your hand, and we'll get people on to ask questions. I will start off. I would like to just talk about stakeholders and your interactions there, and to see if you could go in just a little bit more detail about what that was like. And I'm particularly interested. I know North Carolina is relatively unique in having, in the health service department of HHS, having a chief data officer. So did you interact with their office, and what worked well, or what did you learn from the interactions with the state?
Yeah, Emily, do you want to take that one? You had the most interactions with them.
Yeah, sure. So I'll lead with this. I prior to this project didn't know that many stakeholders there, but Sarah, one of the PIs on the project, knew a lot of the North Carolina Department of Health and Human Services members and had some previous work experience there. So we definitely built off of her existing relationships. We worked closely with the epidemiologists there. We worked with a data officer who I believe is who you're referring to, their chief data officer, who was very familiar with a lot of their data processes. And then our work went to Dr. Mandy Cohen, the secretary of the Department of Health and Human Services, and we met with her on a couple of occasions as well. And then she reported to the governor. We didn't work directly with the governor, but there was a lot of different information that was exchanged there. So we worked the most closely with the epidemiologists and the data officer, and we would have weekly meetings, which were really effective to show different pieces of information too. So I'll give an example. One of the early visualizations we had just showed the number of additional beds we thought might be needed to meet demand. So if there were no additional beds needed to meet demand because the demand line we forecast was always below the surplus beds, that number would be 0. But we were told that that visualization by the stakeholders was actually not particularly useful. And what they instead wanted was the actual forecast value of the number of beds that we were forecasting. So that type of feedback helped us tune our plots and our outputs to match what they needed to make decisions really frequently. So some of the lessons learned were there were it helps to have some existing relationships to build off of. Regular meetings that were on the calendar each week helped us kind of make sure that we were constantly talking to the stakeholders and able to iterate quickly, and then being responsive to their feedback. And I think that last piece would be sometimes we would get feedback that we knew we could implement right away. And sometimes we got feedback that we knew was going to take about 4 weeks to put in place. And so being realistic about the timelines for what was a quick response and what was not.
That makes perfect sense. Thank you. There's a question from David Gurari. I'm going to let you speak, David.
Thank you. Thank you for presentation, interesting presentation. You mentioned that your IBM is driven by some kind of large-scale SIR model. I wonder how you try to do forecast with this SIR. Is it some kind of bulk state-wise SIR model? Does it have any spatial structure or whatever? If you can provide some details.
Sure. So we built a single SEIR model for each county. We used historical data to kind of kick off the initiation of that model on whatever day we were starting with. So say we're starting with March 1st, we would use all of the historical cases up to March 1st to kind of estimate how many people are still exposed, how many people are still infected, how many people are already recovered, how many people might go from recovered to susceptible, as their immunity wears off. So that gave us kind of the initiation. And then it was a basic SEIR run for 30 days to give us the level of new infections each day. And we converted that into case counts. The input for that, and as far as like the forecasting piece, is that RE value. So how quickly is the disease spreading? That was obviously the harder part, especially in 2020. RE projections and estimates were all over the place. And then forecasting what the RE would be was almost like a no-go. Like no one was really getting that, spot on. So instead we created 3 different bands of RE. So we did like 1 to 1.2 as kind of like a slight spread, a 1.2 to 1.4 being more of a moderate spread, and then 1.4 to 1.6 being more of a quicker spread. And we presented all 3 to our stakeholders to say, like, we're not sure where the RE is going to be, but here is what it might look like depending on what, how quickly the thing spreads.
Thank you.
And the SEIR stuff also available, all that code and the ability to rerun that analysis or use it for future analysis is, again, all public.
Mm-hmm. And SEIR had some uncertainty in your predictions. You allowed accept different scenarios, right? You mentioned.
Only with the RE value. We didn't do varying runs of that, just the RE.
Okay, thank you.
Great, thank you. We have a question here from Anuj Mubai. Can you please give some examples where your modeling forecast did not work and why?
Yeah, I think there's 2 main pieces. Emily kind of showed you that when we didn't have good input data, we didn't get great output data. We were using 2018, I believe at the time, historical hospitalization bed counts to help run our model for 2020. And that caused a lot of issues with our projections because our data was 2 years outdated. People were not going in for elective surgeries or procedures that had kind of been stopped. And so we were kind of guessing how full hospitals were. We didn't have that data. So early on, it's definitely easy to see that our forecasts weren't that great. And then also that RE component that I mentioned, we didn't know where it was. So we didn't know what it would be. And if you look at, our forecast when RE was 1.2 over the next 30 days, it was pretty good. But if you look at our forecast where we said maybe it'll be 1.6, it was way too high. So, that's a retrospective thing. Like if you know the RE, then you get really great results. If you don't know the RE, then you present a bunch of results and you're not sure which one it would be. I'll also mention the region. We aggregated things to regions because individual hospitals had less accurate information, especially early on. We had no hospital specific data other than historical data. So we didn't want to present individual hospital forecasts. We weren't confident in those at all, but we were more confident at a region level.
Excellent. Thank you. Great. Does that give you any possibility of sort of modeling your confidence in the data from any given hospital or facility? Or is there any utility in that?
I'm not sure. I don't think we'd have a great way of, assessing how good the data is coming from the different hospitals. We did notice kind of bugs in the data. The names would change often. The estimates would look a little different from time to time. I mean, it was individual hospitals reporting their own data, and we were trying to do fixes on the fly to make sure that it was in the right format, the right number of hospitals. And DHHS worked with us a lot on, looking at that and making decisions on that.
I guess one possibility for doing that would be sort of, rather than doing a single retrospective analysis of accuracies, like if you had a framework to assess your previous week's accuracy each week, you could do that by hospital and maybe over time find certain hospitals with higher or lower error rates, which would be really cool.
Yeah, agreed. Okay, we're just about the top of the hour now, and I'm not seeing any other questions. So I think I'd like to thank everybody for your presentation. Really interesting stuff and really important, I think, to take into account the perspectives of what can be learned by working with the policymakers and working in collaboration with the public health folks. It's something that we all like to aspire to, and I think we'd love to see more about that. There's a note from somebody in the chat that you might want to take a look at from Robert Canales. So please take a look there. And I'll say thanks, everybody. The talk will hopefully be up soon on YouTube, and we'll look forward to hearing more from you all. Thank you.